You're listening to Don't Tell Me to Relax, the award-winning, no-nonsense, always friendly, down-to-earth fertility podcast. I'm Hannah, a fertility acupuncturist and big believer that fertility care and education should be better. Each week, I sit down with a guest to share real stories, advice, and honest conversations to help you feel better informed. And for care and connection, we have our Don't Tell Me to Relax online fertility community and our clinics in London and across the UK. To find out more about getting involved and working with us, the details are in the show notes. Don't Tell Me to Relax is proudly sponsored by the lovely people at Acupips. Acupips is the original ear seed company founded by acupuncturist Zoe Young. Ear seeds are tiny seeds or metal beads attached to an adhesive and placed on pressure points in the ear. They're brilliant for calming the mind, easing anxiety, and restoring balance. We use them in our clinics all the time. Head to acupips.com to find out more and use the code RELAX for 20% off. It is Endometriosis Awareness Month, and so our next few podcast episodes will be discussing this topic. And we are kicking off with 10 things to know about endometriosis and fertility. And who better to discuss this with me than endo expert queen herself, Louise Collyer. So Louise is a fertility acupuncturist, a herbalist, a functional medicine practitioner, and I'm very happy to say is a member of our team working up in Newcastle. So Louise, thank you, my lovely, for coming on and doing this with me today. It's lovely to have you back on the show.
Thanks, Hannah. That's quite the intro. And I hope the listeners aren't sick of hearing my voice yet, because I was here quite recently.
You've got so much to say. I do not think that would happen at all. So we are going to really get straight into it because we've got a lot to discuss today. And we are talking about the intersection of endometriosis and fertility. And so we're going to cover 10 different areas. And the first one is going straight in with this idea that endometriosis means infertility, that you hear those words and you think there will be a fertility issue. So would you like to unpack that a little bit for us?
Of course. So, and I'm sure you've had plenty of patients who have come to you who have suddenly received an endo diagnosis and immediately start to freak out that it spells the end, that it's game over, and they can't imagine themselves conceiving either naturally or even with IVF. But it is not a fertility sentence. And we've seen so many women who, I mean, years ago, I had one girl who, and it's not a very PC thing she said, but she said, I have got the Gaza Strip inside my body. That's how how she visualized it. And she said, and if I can conceive, anyone can conceive. And, it was the standard presentation of endo with, deep infiltrating, some tubal damage. It was bad. And I keep seeing women conceive when their endo is at stage 4 or there's all kinds of mess going on there. So it is absolutely, it's not a sentence. It does increase complexity, but the reason this is number one is because it's the most important takeaway, that endometriosis does not equal infertility. And I want everyone to leave this podcast with that, because I'm almost sick of reading books where they introduce endo as a theme for the character. And the first thing the doctor will say to the character is, so it's likely you might never have children. And whilst I like seeing endo being discussed in books, I just wish that we weren't always immediately going to that as the first thing the patient needs to know, because for us, it's not true.
Okay, great. And because there is often that statistic that we hear, isn't there, about 40% of people with fertility issues have endometriosis. Is that the statistic?
Yeah, I don't know the exact number, but we hear about it being very high, don't we? That those
We
with
do, yeah.
infertility, there is a huge proportion of them that will have endo, apparently, whether it's silent or known about. Yeah.
Yeah. And I guess that is terrifying when you hear it.
Terrifying. And I think it's because that demographic of women aren't necessarily implementing a lot of the things that we might go on to discuss in this podcast after this. So, yeah, if they just present, they've got endometriosis and they've done nothing to support their body with the endo, it might increase it. But you and me and all of our colleagues, we look at ways that we can reduce that kind of stat, or what's what impact it's having, for the fertility.
Yes. And so following on from that then, let's talk about fertility and like the environment of fertility, because we know that the environmental factors are really important. So that how does endo impact that? And
Yeah.
what can you do about it?
I mean, such an important thing to know about fertility. It's not just about, are the tubes open and are we ovulating? It's about the inflammatory environment, the immune environment of the pelvis. And this environment is dynamic, it's modifiable, and sleep, stress, gut health, metabolic balance, hormone regulation, all of that will influence the environment. So women aren't powerless. They can change all of those things. They can modify all those things, which means they've got the power to change the environments. And that's what is so important to know about fertility. It's not just hormones and tubes and uterus. Environment is
Yeah.
key.
Yes. And then what about pain then? So number 3 we're talking about is pain. So do we think that there is this association, the more severe the pain, the more severe the endo, and therefore the prediction of the fertility outcome? So is the link as straightforward as that?
No, and this is what is becoming more well known about endo, that a woman could have a tiny pocket of endo, just maybe sat on some nerves, that is causing her agonizing pain, or a nervous system has become highly upregulated because of that pain. And yet, if a surgeon has gone in, he said, "Oh, I found a tiny smattering of endo." And there's women who we have probably seen where they've never really known they've got endo, but upon a laparoscopy, it's discovered that they're absolutely covered in it, no pain whatsoever. But that that coverage of endo is so prevalent, it has caused some damage anatomically. So, and I think that's what's important for women, that if they're in a hell of a lot of pain, then they're made to feel undermined. If there isn't necessarily much, if they can't even find endo on a scan, there's no endometriomas, or, endo can't be seen visually with ultrasound, then they feel like this must be in my head, or, that they're seriously undermined by medics. Um, and it's for those women to know that it's not in their head. That endometriosis could be causing some issues with the fertility as well. And equally, those who are in agonizing amounts of pain sometimes conceive like that. I'm always
Mm.
surprised sometimes by the ones who they have got the most painful periods, but they have no issues conceiving whatsoever.
And just following on from that, what about this idea around silent endo? So we have seen so many people who've been through treatment cycles and years of fertility issues, and then they find out that there was endometriosis, but they had no signs or symptoms about it. Like what is the impact of that in terms of like the fertility? Like why is that an issue, and how can you treat it going forward?
I guess, is the issue, has it caused malformation, anatomically? Are the tubes, like with, one of my girls, a tube was wrapped around the ovary, that was attached to the bowel. I mean, she felt that, so that wasn't silent. But there are cases where, there's lesions all over, all these pockets of lesions all over that will be causing inflammation,
Mm.
but they're not necessarily sitting on nerves or causing pain, so the woman just hasn't been aware that it's even there. Um, there was a patient who came to see me for fibroids that were interestingly caused by HRT. The surgeon went in to try and remove her uterus for her. When he got in there, he said, "Oh, I'm sorry." He told her afterwards, I couldn't take it out because everything was fused together. So you'd been living with endometriosis all these years." She had no idea.
Gosh.
And she said, "Oh, this is maybe why I never had children." It had never been discovered.
Yeah. Yeah. The next one is around ovulation. So ovulation is step 1, and then so tell me more about ovulation and endo.
So o- we fo- fertility does tend to focus on ovulation, but I think so much of what we focus on in our work with patients is sometimes more about implantation. So for implantation to work, and this is why I say, IVF takes care of one thing. It almost takes care of the ovulation side of it. It gets the eggs out and it introduces the sperm to that egg. But it's all the things that happen after ovulation or egg collection that IVF can't necessarily have a lot of impact on. So it requires immune tolerance, progesterone responsiveness, and a receptive endometrium. And in endo, all of those signaling pathways can be altered, but those pathways are physiologically responsive, so they can be supported.
So how would you support them? What would you do?
So, I mean, I obviously love herbs for improving, like, the quality of the endometrium as well. So if we're thinking about the responsiveness of the endometrium, what can we do to improve that microcirculation? We can use acupuncture, we can use herbal medicine. There will be certain, like, naturopathic, supplements that can be taken to perhaps improve the quality of the endometrium. Progesterone responsiveness, I'll try and come to that in the next one that we'll discuss, actually. Immune tolerance. So let's think about that. Is there something going on from a microbiome level that's agitating the immune system? Some of our patients end up having to use certain medications, right? So prednisolone, intralipids. So we're thinking about the things that try and mediate implantation and make the body stop fighting it as much.
Mm, mm. Okay, and so number 5 is endometriosis is an immune condition because I guess for a long time it was thought of as a hormonal issue, and there was always a lot of talk around this idea of it being triggered by estrogen, and that's sort of where it's at. But this idea of it being an immune condition has kind of gained more and more credence,
Yeah, that thing.
credentials. Anyway, you know what I mean. As time has gone by, so what are we? Why is that? What
Yeah,
do we know about
so,
that?
endometriosis for so long was classed as a menstrual disease. One of my girls, she said, "Oh, I don't know, understand why it's a menstrual disease because I've never had any problems in my periods." It was more
Mm,
like, I had shortness of breath, I couldn't breathe, I had pain in my, she had diaphragmatic endo. So she was like, "For me, it's nothing to do with my period. It's this whole body experience." So it's when we start to think about it from an immune side of things, the lesions that are in the body are things that shouldn't be there. And, the immune system knows this. And so it's constantly trying to fight the lesions. So you have this chronic inflammatory response going on. And that inflammatory response plays havoc with trying to get pregnant as well, because again, it's all about the environment that the eggs are growing in. And if all of those lesions are in the pelvis, all of that inflammatory response is often going on in the pelvis as well. So, but again, the great thing is we can have an impact on the immune system. So if the immune system is fighting a pregnancy, like we've said, sometimes there's medications people can take to downregulate the immune system. We can come at it from a food point of view. So, I love to do a very specific food sensitivity test with my patients that shows me, are there any foods that are reacting here? And do we have leaky
mm,
gut going on? And how can I calm everything down so that we're not constantly breaking out in cold sores, we're not getting rashes, we're not having all this gut distress? Like, how can we come at the immune system? And
mm.
that is great for an endo woman who's not even trying to get pregnant, but for the ones who are trying to conceive, it's a brilliant way to um, try and improve the odds for conception.
Yeah. And just thinking about that, Louise. So when people turn to IVF as a solution to their fertility problem, and they often say, I've got endometriosis, so I'm going for IVF. Can you just sort of unpick so for some people that's absolutely fine and everything works out okay, but for other people, it's not necessarily the answer. Can you, and I'm just thinking about this in my own head now out loud, is that that environmental factors. So can you just unpick why for not everybody that IVF is always the best route forward?
Yeah. So, why was IVF invented? It was for women with blocked tubes. So this is what I say to everyone. If we have blocked tubes, yes, thank goodness we've got IVF. And that's what it's for. But like I said previously, IVF doesn't take care of the second part of it, which is implantation. But it also, if we're going in to collect eggs, if those eggs, which have got a 4-month we kind of think of the life cycle of the egg as being 4 months. If those eggs have been exposed to all that inflammation over 4 months, when we have IVF and go in and collect them, then what are we collecting? We're collecting these poor, damaged things that haven't had an easy ride and might not then fertilize well. The maturity of them might be affected, and it might lead to poor embryo development. So if you are an endometriosis woman with tubal damage, if it's likely that your eggs and sperm can't meet, then yeah, IVF is for you. But otherwise, IVF won't necessarily be the fix for all of those other components that endometriosis impacts on.
Yeah. Okay, number 6, you have put pregnancy isn't a cure, because this is what so many women are told. Have a baby, it will sort out your endometriosis. So what is the problem with this statement?
So pregnancy obviously calms it down for 9 months. If we breastfeed after that, maybe calms it down again. Although so many of my endo girls their periods will return even if they're breastfeeding. Because those hormones are aggressive often in an endo girl, or they can be quite gung ho. So what we need to take away from this whole thing about pregnancy is it's this progesterone. The progesterone is key. In pregnancy, progesterone really rises significantly. And so it's that response that matters in pregnancy. So we're not thinking, oh, pregnancy is the cure. We want to ask, how do we improve hormonal responsiveness? So we do this in a few ways. We want to lower the inflammatory load. We want to improve estrogen metabolism. We want to support mitochondrial function, and we want to regulate the nervous system. So if we do all of those 4 things, often we can improve this progesterone receptor sensitivity. So, it's progesterone that's key. It's not necessarily pregnancy that's key. It's just one of the outcomes of pregnancy is the benefits of progesterone.
Mm. Okay. And then we've got this idea about the goal is to improve responsiveness, so not suppress the body. So I guess so many people are told to go on the pill or to have kind of contraception as a way of calming everything down. But
Yeah.
obviously, this really isn't a long-term solution. I mean, I've had people who've been offered basically a hysterectomy or long-term pill use as their options to treat their endometriosis, which obviously might not be suitable for you. And if you're trying to get pregnant, then it's absolutely ridiculous. So what can you do about that? And what
Yeah. I
what
mean,
can the goal be?
for our listeners, none of this hormonal contraceptive is going to be applicable or relevant, right?
Mm,
Because if they're trying to conceive, we need to stay well away from them. But so many of them have probably come to us having had a Mirena coil in. Some of them have also been on a progestin, you know, um, contraceptive, and that's like the mini pill, maybe. Some of them on both of those things at the same time. Sometimes I just try and stop them from bleeding because it's for women with adenomyosis, in addition to endometriosis, it's the bleeding that can be really problematic. So we have to think when we get a woman and we don't want to use contraceptive and it's not an option for her, how can we help the body cope with regular periods? Because that's what, cycling is going to give us. This is what is so hard for our patients because they have to have periods when they're trying to conceive because
mm.
that's the cycle, isn't it? You ovulate, you bleed, you ovulate, you bleed. So we have to think, how can we make those periods an easier ride? How can we make ovulation an easier ride? So how can we make that whole song and dance of the cycle easier for them to cope with? And usually it's by downregulating inflammation and trying to support, especially estrogen metabolism.
And so when you talk about estrogen metabolism, can you explain a little bit more about that in case somebody's not heard about that before?
Yeah. So again, because this idea that some endo women have too much estrogen, and they might have a very normal amount of estrogen in their body as opposed to a woman who even doesn't have endo either. Some of them might even have less estrogen, but I think it's sometimes how their body is coping with that estrogen load. So I see a lot of endo girls who have got constipation. So they are hanging on to their waste material in the gut. the liver does this thing where it's sending metabolized hormones to the gut. It's tackled them and it's sending them for excretion. If we're constipated, then those hormones, those metabolized hormones, they sit in the gut and they get reabsorbed into the body. So you can end up with what feels like this excess estrogen, going out your bloodstream. So for estrogen metabolism, we want to support the liver to do its detoxification. We want to support the bowel to clear the waste out of the body. Um, so this is kind of what we talk about, with estrogen metabolism. We're like,
Mm.
let's just help it shift out. We don't need it in there anymore.
Yeah, because I guess gut health issues are so common with endometriosis. They seem to go hand in hand. So,
Yeah, really common. And, it can be because, a woman who's in a lot of pain, a lot of tension, often the bowel is spasming or things just almost grind to a halt sometimes. There can be issues with SIBO, there can be issues just with general motility, microbiome issues. Like we see so much gut stuff going on with endo girls.
number 8 is around surgery because this is a question that we get asked a lot. And it's such a dilemma for people, especially if you're preparing for IVF or you're trying to conceive naturally, whether you should have surgery or not have surgery. So, can you tell us a little bit about that?
Yeah, I mean, it doesn't help that different consultants will say different things, and you hear one expert, absolutely advocate for surgery. You'll hear another expert say, "Well, when it comes to fertility, we should try and stay away from it as much as possible." Um, there's two kinds of surgery for endo. We've got ablation and excision. So ablation, I joke, is like the blowtorch. An excision is like the trowel that goes to the root and tries to pull it out. And a lot of consultants are very hesitant about doing much in the way of surgery in a patient who they know is going to try and get pregnant because you risk damage to the ovaries. You can sometimes even risk damage to the bowel, and then the patient might have to have like a stoma bag. So if if surgery can be done by a consultant who really is an excision specialist and an endometriosis specialist, they can often do it in a way that really, really reduces any fertility damage and sometimes can put a woman out of a lot of pain. And I have seen surgery do incredible things. The patient I said whose fallopian tube was wrapped around the ovary and that was attached to the bowel and it was a hot mess in there, when they kind of untethered that and released the fallopian tube from the ovary, she went on to conceive twice naturally. They were preparing her for the IVF. She was on downreg, and she was one of those amazing cases where everything had been freed up and she could conceive. So I do see the wonders of surgery, but we just have to just be so careful that the person who's doing the surgery really knows what they're doing when it comes to endo, knows how to identify it, and I think is experienced with excision surgery.
I guess it makes sense to think about addressing the lesions because of this reduction in that level of inflammation. But I think there are other ways to think about that if you are preparing for an IVF cycle and you don't want to have surgeries. And obviously, all the lifestyle things, all the herbs, acupuncture, all that kind of taking a wider holistic look at it might be more helpful for some people.
Exactly. If we can downregulate inflammation with lifestyle changes and naturopathic approaches, then that might actually be better in the long run because by removing lesions, you can risk creating adhesions and scar tissue.
Yeah.
And, surgery is not without risk. One of my endo girls ended up with sepsis from, her bowel being punctured. In the removal of the endo, we have to remember it's not without risk. So
Yeah.
if we can do it lifestyle first, this would, I think, always be the best approach. If you can put her out of pain and improve her fertility without surgery, that would always be my preference.
And so the next one is around this idea of egg quality, because there is always this theory around the eggs and the environment and the impact that an endo picture can have on that. So, is that the case regardless of age? Do you think it gets worse as you get older? Is it the severity of the endo? What are your thoughts on that?
Yeah, I mean, I think with endo, it becomes more compounded with age, doesn't it? Because it's almost like we're
Mm,
fighting two battles. We're fighting the chronological aging of eggs, which we all very much try to reverse as much as we can. But if we've got age in addition to endo, this is where it can become a little bit more stressful. And that's sometimes the one instance, I think, where IVF might sometimes be of benefit if we can extract more eggs in this particular time rather than one egg a month over a 12 to 18-month period. IVF might enable us to just get those eggs out before any more damage is done to those eggs.
Mm.
But it just oh, go ahead.
No,
It
go on,
comes
sorry.
back to those modifiable factors, right? So the eggs, the quality of the eggs are influenced by inflammation, metabolic health, mitochondrial support. They're all modifiable. So what can we do again to reverse the damage?
I'm seeing a new thing more and more, which I really like, is this idea of collecting eggs, creating embryos, freezing, taking a pause, and then thinking about environmental factors. And I know we were talking about that at the beginning. Some clinics do it and they do very bespoke treatment plans specifically with somebody with endo in mind. So for example, I've got somebody who's done 3 months of down regulation, complete downregulation before having an embryo transfer, with this idea that that downregulation is really switching off that inflammation. They're not having that monthly response by having a menstrual cycle and that rise in estrogen. It's not a standard practice. So, for example, in NHS clinics, I'm not seeing, no disrespect to NHS clinics, but they just don't have that ability to have that bespoke method to treat people who might respond better with that kind of approach. What
Yeah, I mean,
what
at
do
the
you
risk
think?
of being a bit down on the NHS approach, it's all to do with economics, isn't it? So
Yeah.
they try and avoid frozen rounds. They would always opt to do a fresh round first because by doing a fresh round, they get rid of one of those embryos sooner. I think the less embryos they put on ice for the patient, it's just like the less money it will cost them. So with
Mm,
all of my patients who are going through IVF under an NHS clinic and they've got endometriosis, they're almost forced into having a fresh embryo transfer. But we know that in private clinics in America, clinics in Europe, they are more willing to do frozen rounds. Let's get the eggs, let's turn them into embryos, and then let's calm everything right down before we then go in and do an embryo transfer into a uterus that might be equally inflamed, especially if we've got adeno in there.
mm,
My preference is always let's try and calm things down as much as possible before we then do an embryo transfer.
mm. And the last one, which I have to say is my favourite, Louise. So the nervous system is a fertility organ. I love that so much. So tell us a little bit more about what you mean by that.
Yeah, I mean, I thought you would like this because this is the
Yeah.
acupuncturist superpower, isn't it? Our influence on the nervous system. And we have to be very careful about saying, stress can cause infertility. And, stress is one of these things which, um, well, yeah, just like all the other things we might say is a factor of infertility. I do actually think stress can have a huge impact on fertility. Chronic stress increases inflammatory signaling, it alters immune tolerance. So I genuinely believe that regulating the nervous system isn't this fluffy thing that we say we can do and try to do. It changes physiology. Um, so when we reduce sympathetic overdrive, and if you think about, is the sympathetic nervous system in overdrive or underdrive? Is it in fight, flight, or flee? Or is it in rest, digest, or reproduce? When it's in the rest, digest, reproduce, we're supporting hormonal communication and implantation signaling. Everything is ripe for conception. And this is what we love to do with acupuncture. We love to downregulate the nervous system and make it optimal for conceiving. What we don't want is for the body to constantly be like, there is a predator and I need to run away from it. If we can make the body feel like, everything's great. It'd be a good time to have a baby. This is almost what we're doing when we pin our patient on that couch and make them lie still for 30 minutes. So, yeah, I love
Yeah.
it being described as a fertility organ.
Yeah. That is I'm going to take that. I'm going to take that
All
with me. So, if somebody is listening to this, somebody's listening to this and they've got endometriosis, they are trying to conceive, let's say they're trying to conceive naturally, they're struggling, it's not happening. What would be your advice?
So, I mean, if someone's in front of me, if someone's in clinic with me, I always say, first of all, let's look at your diet. Let's look at what we could kind of reduce the burden on your body. So many endo women struggle with gluten. And I've got a girl at the moment, she's been with me for years because we do endo management. And she'd been off gluten for years. And she's like, I'm just going to experiment and see how it goes. She's had her uterus taken out for adenomyosis. She was feeling great. And she started, eating sourdough pizza and enjoying some gluten. And 1 month on, she's like, yeah, it's just not working, is it? Like, my body just does not like it. So most endo women, if we take gluten out, it just gives their body a rest. Increase your polyphenols as much as possible. So make sure you're eating the rainbow as much as you can every day. Polyphenols are key because they're an antioxidant. So how can we reduce inflammatory load? We do it with food. We can do it with supplements. There's various supplements that reduce oxidative stress. I guess we think ubiquinol is a classic, omega-3, curcumin. Google and ChatGPT will have it all there for you. And then I love to suggest modalities like, acupuncture, herbal medicine. These can also really calm everything, nervous system. It can improve the quality of the blood. Yeah, there is a lot that can be done, if
Yeah.
you've been diagnosed.
Yeah. You know what I'm going to say? I'm just going to throw this in because I see this quite a lot in that somebody comes into clinic and they have a diagnosis of, let's say, endometriosis. And what happens is that all of the focus
It's on
and
her.
that is on her,
Yeah,
exactly.
and
And
that
that
was forgotten.
person, yes, and they would have had it that, they've suspected they've had it since a very young age or when they started having their cycles. And they often have often thought, I'm going to struggle to conceive and it's going to be my issue, and I'm sure you see people like that in clinic. And actually exactly like you said, we forget to look at the man in that
Yeah.
picture and all of the focus. And it's like, well, she's got endometriosis, so she must have the fertility issue and he is completely forgotten. And it never fails to amaze me how many times that we discover really it might be a part of the problem, but there is more of a problem going on with the man and it's been completely missed.
Yeah, absolutely. Time and time again, to the point it's boring now.
Yeah. It is. And just I want to ask you one more question. If somebody is preparing for IVF with endo, again, what would you say would be your top kind of tip for to pass on to somebody to really help support them through it?
I would ask them to advocate for themselves as much as possible with
Yeah,
the clinic and ask the clinic to treat them as an endometriosis patient because so many clinics just treat them as, your standard woman who has nothing going on.
yeah,
Um, and sometimes you might be up against a brick wall, but make sure she knows that her progesterone levels are optimal, So it might be that she needs not just cyclogest, but she might need Lubion. She might need more in the way of progesterone support because she might have some progesterone resistance. So, I think something like that is key. Advocating for yourself and knowing what you might need additionally over someone else because you've got endometriosis.
yeah. And I guess that's a good question to ask, isn't it? When you have your consultation, is well, how are you going to treat me? What are you going to do differently because of my diagnosis of endometriosis? And it'd be
Exactly.
interesting to see what they say.
Yeah, and if they say nothing, warning, and you can have your IVF at another clinic. If it's NHS, you can go to a different hospital.
Louise, as always, thank you very, very much. It has been a pleasure to speak to you. I will put all your details on. Louise does lots and lots of work with endometriosis. So if you want more information, it will be on the show notes. So thank you, as always.
Thanks, Hannah. This has been fun, as always.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.